This is The Common Health from the CSIS Bipartisan Alliance for Global Health Security, engaging senior leaders on questions of how to address our common health security challenges in this post-COVID moment. I'm delighted today in this episode to be joined by Raj Panjabi. He's a close friend, someone we've much admired. He's soon to become a non-resident fellow here at CSIS in the CSIS Bipartisan Alliance, Global Health Security. He's an American physician. He served most recently February of 2021 to August of 2023 in the Biden administration, first as the head of the President's Malaria Initiative, right, as the coordinator, and then a stint as the senior director of the NSC Directorate for Global Health Security and Biodefense. And we'll be talking about that. Welcome, Raj. It's great to have you here with us. Thank you for making the time.
Thanks, Steve. It's good to be back here.
So I wanted to start with your personal story, which is a fascinating one. Tell us a little bit about your early life in Liberia, your family's decision to migrate to North Carolina, your upbringing and pursuit of a medical career there, and then how you came to launch Last Mile Health and find yourself full circle back in Liberia. Talk about that story. I'm not sure how many people understand that story, and it's so much of who you are.
My parents migrated from India to West Africa in the 1970s, and I was born in Liberia. I lived there until I was 9 years old, kind of life most children would dream of, kicking around a soccer ball. I was in the 4th grade and loved science and math, and then things changed for our family. That year in 1989, Christmas Eve, I was 8 years old. Charles Taylor started the Civil War against then authoritarian Samuel Doe, who was the president of Liberia at the time. That led to one of the 20th century's most devastating and brutal civil wars. It drove my family out, along with many others, and we ended up resettling in North Carolina, in High Point, North Carolina, where my parents still live. And we were welcomed by an Indian immigrant community, helped house us for a while, and then helped my parents get started in business and in a clothing shop. I actually still get my suits, even the one I'm wearing right now, from my mother's shop. That put me through school, put my sister through school, my younger sister. I went to Carolina to college, both for undergraduate and then med school. And I had, wanted the war not to write the last chapter in my story and in my family's story. And so having started to train in medicine as a medical student, I decided I wanted to go back to Liberia to see if I could help serve the people we'd left behind. When I got back, Steve, in 2005, so it was 16 years to the day the war started. So it was Christmas Day, 2005. I arrived. My then fiance, who later became my wife, joined me on that. Amisha Raja, who's a mental health expert, psychologist. We were concerned about the health impacts of the war. And we discovered, I was volunteering with the Ministry of Health, Liberian Ministry of Health, and we discovered that there were only 51 doctors left for a country of 4.5 million people. Now, those are large numbers to think about, but if you were to put it in perspective, we're sitting here in Washington, D.C. It would be like all of D.C. having just 8 physicians to care for the entire Washington, D.C. population. In this case, it was even more difficult than that, because if you got sick in the city where those few doctors remained, you might stand a chance. But if you got sick in the rural, remote areas, you might die anonymously from diseases that actually we know how to treat in the 21st century. HIV and AIDS was a ranking concern. Malaria still was biggest killer of children. I had had it several times as a child there. And we went to work, initially volunteering as a clinician in rural public hospitals, and then launching Last Mile Health to help close the gap in access to rural health care. And we started with a very small sum of money, about $6,000 from my wife's friends at our wedding. We asked forego the plates and spoons and coffee makers.
Catch up on those later.
Right. And we used the $6,000 to, in many ways it sounds romantic, or maybe it doesn't, but it more probably reflected our naivety and also our earnesty to just want to have to do something in the face of such seeing people die from childbirth in the 21st century shouldn't happen.
What was the concept that you had about last mile health? Explain that.
Well, given the doctor shortage there and also the nurse shortage, I had come along an idea that I first discovered in my first job in public health, very far from Liberia and even far from here on the Alaska tundra, working with the Alaska State's Community Health Aid Program. Alaska's got a landmass that's 20% landmass of the U.S. They also have had a doctor shortage in rural areas. And so what they did was actually look within their communities to hire, train, and equip local women, largely, but also men, to become community health aides or community health workers, as are known in many parts of the world. And we wanted to apply that approach in rural Liberia. And the government, President Sirleaf at the time, had been elected as Africa's first woman elected president of any country in Africa. And she wanted to put that forward. It both addressed a healthcare access issue by hiring, training, and equipping largely unemployed. Many people all didn't have a medical degree, but most of them didn't even have a high school degree. But we enlisted the community to become part of the medical team. And we were able to take on HIV and AIDS. Using that approach, the mortality rate dropped by about 60% over the subsequent years. And take on malaria. By the time 2021 arrived, when I was just about to join the Biden-Harris administration as the president's malaria initiative coordinator in that first year, we had discovered that this model of hiring local people as community health workers to extend the reach of the medical team was actually responsible for treating 1 out of 2 rural children in Liberia by bringing tests and medicines to the doorstep. It's also been incredibly useful to President Sirleaf during history's worst Ebola outbreak, which we experienced about a decade ago, as you know. And without door-to-door contact tracing, without the work that community teams did to strengthen safe burials at the time, we wouldn't have been able to essentially hunt down the virus and stop it in its tracks. So that really became the centerpiece of Last Mile Health's work. And today, we started with $6,000 in one community, and today Last Mile Health is working with several governments across Africa to support tens of thousands of workers who are reaching millions of people who otherwise would have been out of reach of care.
Tell me a little more about the Ebola response. I mean, during that crisis, we traveled to Liberia. It would have been in January of 15. So it was after the worst, but it was still pretty ragged. It had peaked in December and come down pretty fast, but people were pretty shattered, pretty traumatized by all of this. Tell me a bit about how you were able to perform in that period.
Well, it was frightening. I mean, to be just quite candid. I had been working back in the country, of course, shuttling between there and Harvard Medical School, where I'd also been a medical professor, for about 9 years by the time the first cases arrived in Liberia. And within months, the disease spread like wildfire, largely because we had very little testing capacity, and also because we still had a shortage of health workers in rural areas where the disease first likely spilled over from possibly a bat, it's thought, into humans. And those blind spots in healthcare led to hotspots of disease. And that eventually reached a point that we saw people dying on the streets. We saw hospitals overwhelmed. We had projections from the CDC, the American CDC, that there could be as many as about over 1 million people infected with this disease, and most of them would die. It was at a time we did not have access to an approved Ebola vaccine. So that was the conditions. But, the same challenges that play out in almost every pandemic and epidemic, fear and mistrust and the tension between the most affected communities and authorities really came to my attention in a big way, especially after President...
Yeah, the riots.
The riots.
And you had the military called in to West Point.
To West Point. It's just a mile away from where I grew up. And after the military was brought into this area that was the poorest part of the country, frankly, in terms of the urban population, a little boy, you'll remember, the community, of course, was forcibly quarantined, and they pushed back. And in the confusion, one of the soldiers fired, and a little boy lost his life, a young boy, teenager. So that, to me, was the bottom of the trust fallout. And what was perhaps most remarkable to me is a moment like that, leaders, public health leaders, elected leaders have a choice to make. Are they going to continue to see the community as objects of our interventions? Or might they partner with those affected communities to be agents in the work? President Sirleaf decided to enlist communities to be part of the response, but symbolically, she made the choice the next day to go out and apologize to the relatives of this young boy. And that, for us, symbolically, set an entirely different tone about how the government was going to respond. And over the subsequent months, tens of thousands of local community members, like people in West Point, became part of the response. And that, I think, then changed what the trajectory of Liberia's outbreak was then, but also became relevant during the COVID pandemic. Those same community health workers became part of a national workforce who then combated vaccine hesitancy during COVID in a pretty ingenious way, Steve. They got vaccinated amongst the first health workers, and then hesitancy and misinformation was rampant there in Liberia as it was anywhere else. At this point, I was in the Biden administration working on the global COVID response for the president. But they had one of the most ingenious approaches where those community health workers took a vaccine and then wore their vaccine cards on their sleeves to show their neighbors that it was safe to take it. That's the kind of shift from tension between affected communities and authority to partnership between authority and communities that I think is so vital in an age of mistrust in science and in public health.
So it's quite unusual, frankly, to have someone with the experiences that you've just described migrate into the White House, into a senior director position. It's not often that somebody with your body of experience makes that migration. There's maybe a few other instances of this. It's quite unusual. So let's skip ahead. Next thing you know, you're at PMI and then you're at the National Security Council. As we're tipping out of the worst of COVID, but with lots and lots of work along the way, along with the other things that appeared, Mpox, for instance. So it was still a very busy period putting together this strategy, the biodefense strategy, coordinating the follow-on phases, dealing with the residual toxicity, divisions around all these interventions, and dealing with this misinformation and partisanship that had become so heavy in this period. What were your proudest accomplishments from that period of service in the administration? When you look back, what are you going to tell your grandkids first out of the box?
Let me just say earnestly that my accomplishments, when you work in government especially, it's always not just a team, but a team of teams that's working on these efforts. So I, in many ways, just was holding the baton from others. I would say at PMI, at the President's Malaria Initiative, helping push for the decision to launch the world's first malaria vaccine and open up a window at Gavi to have $150 million go in to help roll out RTSS I feel very proud of the fact that the PMI played a key role in that, but also continued by rolling out the new 5-year strategy that my successor, Dr. David Walton's taking forward to prevent another billion cases and help us actually achieve the end of this disease within a generation. At the White House, the day we were launching the strategy is the day I got the call from the White House asking me to consider coming over to replace, you can't really replace Beth Cameron. Her shoes are so big, but Beth and I had worked together on the first COVID summit that she'd spearheaded, where the president made a commitment to help vaccinate the world and share over hundreds of millions of vaccines. I think the actual first number was over 1 billion vaccines, and to help vaccinate 70% of the world. Beth handed the baton to me, and again, she had built such an incredible foundation of work. I had a chance to help steward for the president afterwards with the agencies. I'd say there's really 2 major things I feel proud about in the White House. Number one, the vaccination campaign, both here and around the world, saved many, many lives. I mean, the numbers, I'm an epidemiologist, so I objectively just looking at reports like the Commonwealth Fund report that showed just in the first 2 years in the United States, hundreds of million shots went into arms, 3 million American lives were saved, $1 trillion of economic loss was averted because hospitalizations were prevented. Around the world, the United States played a major role, in fact, provided the lion's share of funding for the over 50% of the funding, according to OMB, for the global COVID response. That included direct vaccine sharing, as you know, hundreds of millions of vaccines to over 115 countries, but also providing direct support to Gavi for COVAX and CEPI, and to the Global Fund for the therapeutics and for PPE. All in all, the first year of the vaccine rollout globally, the Lancet reported that over 20 million lives were saved, with now, up to this point, some 13 billion shots have been provided for COVID as of early this year. I think the United States should feel proud of their commitment. But the second thing that I feel deeply proud about is that we didn't say that that was enough. President Biden came into the White House, and his first executive order on day one in his National Security Memorandum was to reestablish the office that Beth and I had a chance to lead at the NSC and the COVID team. But he gave us a mandate of doing better, knowing that when you face biological threats, you have to have biological humility. These viruses know more about us by the time they are in us than we know about them. That means we can always do better. And so the biodefense plan that we put out, that built on the American Pandemic Preparedness Plan, to put out pandemic moonshot goals that we should aim and build capabilities for vaccines within 100 days of the next pandemic, and therapies, repurposed therapies within 100 days, that we should ensure that global health security is central to our national biodefense and put funding behind that was critical. And just to give one or two examples of initiatives that I think we feel help move the ball down the field. One, of course, was helping unlock about $12 billion in funding, according to OMB, in the FY22 budget for about 16 federal agencies to take forward the work of advancing biosurveillance, vaccine, diagnostics, and therapeutic development to be more rapid, investments in health systems here in the U.S. And then on the global front, the Global Health Security Act, that was a bipartisan effort, I think allowed us to do a couple of things. I think it allowed us to get $5 billion of new funding authorized for global health security, to ensure that the pandemic fund was able to be authorized in terms of getting some of that funding. We had launched that through the president had through the G7 and through the G20 in partnership with the G20. And, $2 billion of funding was mobilized, but more needed to be mobilized. And that helps set the foundation for us to be able to, just these past few weeks, finally publicly announce the U.S.'s new global health security strategy, which wasn't just a number of words, but is using some of that new money that's been authorized to help scale up our bilateral partnerships from what were about 17 or just under 20 bilateral partnerships to what's now 50 countries. That's still not enough, but it is a big step forward from where we were.
What were the tougher lessons that you learned in this period? And what were some of the darker moments in your time as you look back? This was not an easy environment at all.
Right.
This was not an easy job that you had taken on. Many accomplishments, but also just a very tough agenda.
Yeah, I think I would say one has to do with mistrust and the other has to do with complacency. Let me start with mistrust. It is, anyone listening knows and has experienced how devastating misinformation and disinformation about COVID vaccines has been and continues to be. There are many American lives that have been lost because people refuse to take the vaccine, largely on ideological grounds. That further eroded trust in institutions, in the federal government. And when we had subsequent outbreaks, Mpox in particular, there was a lot of concern that we would not be able to get testing out quickly enough. When the vaccination strategy needed to evolve very quickly from what it had been for many years to a more vaccination strategy would keep up with the Mpox outbreak that we experienced in 2022, there was a mistrust with the most affected community, the LGBTQ, especially gay and bisexual men who were largely affected. So to me, the power, when Ebola happened in Uganda, the Sudan strain of the virus, there was mistrust with the authorities there in Uganda. And I think, also concern about, in the context of vaccine misinformation and misinformation about infectious diseases in general that did end up affecting that response. So having been on the side of those communities, I mentioned the work with communities in Liberia during the Ebola response as an example, or the Alaskans. I think I thought that it would just be an obvious answer that the government should turn towards communities and bring them into the response. And what I learned is that when you make space for that, when you actually bring communities in, you have to be ready for them criticizing the response. Initially in the vaccine response in COVID, there were racial inequities. In the Mpox response, the most affected communities were struggling to get access to vaccines early on in many cities and towns. In the Ebola response in Uganda, folks were fearful, running away from hospitals. So to me, that was one lesson that maybe I relearned. I do think the more effective responses were when we actually listened to that critique and learned from it, and to the extent possible, empowered communities. So, with the COVID response, meeting people where they are became the mantra of the vaccination campaign. And so globally, that meant actually putting money into hiring local health workers, like community health workers or nurses. In the United States, it meant doing vaccination campaigns in barbershops. In the Mpox response, it meant actually bringing in folks like Dimitri Daskalakis, who himself is an infectious disease physician, worked in the gay and bisexual men community, a trusted coordinator to help us win back trust from that community, but also center them in the response, those communities. And frankly, that's the reason the Mpox outbreak was able to go from 500-600 cases a day down to less than a case a day by 6 months after that point, and the health emergency turning off. And similarly in Uganda, we were able to support the Ugandans to get to 0 cases in less than 100 days because $33 million was unlocked very quickly, in part by the United States, to support local communities to go door to door and help people get the care they needed and protect themselves, like the Liberian example had given. So that's sort of one big example. And the other one, Steve, is around urgency and complacency. Once a large proportion of the population became either vaccinated or infected here and around the world, the general public's sense of the threat of COVID dropped. There's still many people who are vulnerable to it, but that immediately took the political pressure off, especially on Congress. We saw the consequences of that. The president asked for more funding for pandemic preparedness. You'd think after an event that killed over 1 million Americans, more than all the wars of the 20th century combined, that this would be the moment. We put a plan forward, the Biodefense plan, to ask for the largest request of funding. It was about $88 billion in the year FY23, a mandatory request over 5 years to fund biodefense as we do the rest of defense. But with the pressure on the Hill changing on Congress, we never got there. We got $12 billion in annual appropriations, which is a good start, but it falls way short of where we need to be. We're more prepared than we were before COVID, but we have a lot more work to do to get ready.
Let's pivot to where you're suggesting things are moving. I want to combine two ideas together here and ask for your thoughts. We've entered a period that's of uncertainty and anxiety around the global health and global health security agendas. We're seeing them slip as a priority. We're seeing some cuts in funding, $200 million cut in global health security funding. We've seen a very surprising stumble in only being able to get a 1-year reauthorization for PEPFAR versus 5 this last period. We're also starting to see the political ground change, and we're seeing a sort of conservative critique come forward about foreign aid, including global health, to sort of focus on how do we know if we're really getting value, the right value for money, asking for sort of a new look at the metrics of, do we need these budgets for PEPFAR? Have the unit costs dropped so much that we could do better? Asking questions around what is the end game? Is 2030 the end game? And what would that mean in terms of partner countries assuming greater responsibility, and how feasible will that be? And then pointing back at the national security strategy of the Biden administration itself in terms of China, chief adversaries. So what is your thinking on this? We are in this uncertain moment, and there's a debate that's forming. And there's evidence that some of these very worthy things are really much more vulnerable than we thought. with less assurance of bipartisan support. How are you thinking about this period right now?
A number of the individuals who championed initiatives like PEPFAR and the President's Malaria Initiative, PMI, some of them have phased out of Congress. Retired in many instances. We still have some great champions, folks like Representative Barbara Lee. I think Senator Graham and others still feel proud about the leadership those two individuals and many others showed to get us to where we are. Senator Coons is another champion, continues to be a champion of these efforts. So I think that's one challenge, is a cyclical challenge. The second challenge I think we're facing, and that's driving this, is the fact that, folks have felt the threat has somehow subsided. And the third challenge that I see is the growing polarization in our politics. And we all know that the major driver of PEPFAR not being reauthorized for 5 years and being reauthorized for just 1 year, first time in its history, despite having saved over 25 million lives, perhaps one of the most generous things Americans have ever done for folks around the world, and having put us on track to end HIV and AIDS as a public health threat in the next 10 years, is not because of the lack of effectiveness of the program. In fact, it's been very effective, as I just noted, but because those on especially the far right have said that PEPFAR dollars are being used for abortion access, and that should be stopped, which of course has been disproven. It's not being used directly for abortion access. It's being used to provide health care. So I think, to me, those three are the biggest challenges that we face in global health. But I see that we've got work to do on each of those, and we can do work. First of all, we can renew championship. Championship comes from feeling the program, not just hearing about its success. So more opportunities to bring current congressional leaders to places in Africa, in Asia, and Latin America where these programs have had success, to meet the children who are no longer are being infected by HIV, to meet the people who are living now 20 years on who would have otherwise died, I think can move people. And that is one piece of work, to bring folks more proximal to the work, to renew championship. The second, that would also help with the third piece, which is to counter this disinformation around abortion access. The other issue of the threat feeling like it's subsided is to remind people of the biological humility we need in this situation. I mean, let's be clear. When I was the head of PMI, we were starting to detect drug resistance in places like Rwanda to the very effective artemisinin combination therapy, the mainstay of the drugs that we use in malaria. And just these last few months, we've had spread of malaria cases occurring in places like Florida and Maryland. Let's also remind ourselves that most people from America, when they go out to visit parts of the world for business or tourist travel, still have to take malaria prophylaxis when they're going to endemic zones. We need to remind folks that this threat has subsided in part because of our efforts to date. And the only way to keep the threat cornered, to stop it, is to finish the job, to end malaria, as the plans show, and to end HIV and AIDS as a public health threat, to get to a point where we have less infections occurring and more treatments happening. And thankfully, we have folks like Ambassador Kengasong, Atul Gawande, Lois Pace, we have David Walton and others who have put forward a series of plans that with some very clear ask to Congress to help us actually get there.
I do feel like we need to make the point that on the PEPFAR reauthorization, one of the essential elements of getting back on track is we really need a sustained, serious commitment at the highest levels of the White House itself. And that was missing at key moments this last year. There are various reasons for that, but it opened the door for some of what we saw as the opportunists using the bounce from the Dobbs decision on the anti-abortion stuff, which then got in the air, and it became a season of opportunism to grab onto those, full of falsehoods and specious arguments, but it was effective. I want to talk about some positive things here as we close. We're nearing the conclusion, I hope, of the latest phase of negotiations. Well over 2 years of negotiations on the pandemic treaty and a parallel set of negotiations on reforming the international health regulations. We're a short while out from the World Health Assembly, where the products of those labors will be tabled, and we'll see the great reveal on, what has come out of this. You've been watching this closely. Are you hopeful? Do you think we're going to have something that's meaningful? There's been obviously lots of very tough issues at play and a certain kind of chasm or standoff between the Africa and Equity Group on the one side and the global north, including governments and industry. I mean, that's been pretty stark. But people are starting to make some more positive noises about this. What's your thoughts?
There has been some movement in the international health regulations, right, which is our oldest treaty in terms of health. And I think specifically, should they get approved by the member states at the World Health Assembly, and both of these were under my portfolio at the NSC, so I had a chance to oversee White House policy on these and know how committed the U.S. is to these reforms. Number one, on IHR, the fact that we might have an intermediate alert system, the fact that we may have a situation where WHO is obliged to offer assistance and a country has to state why they would refuse it, the fact that we would have mandatory reporting of respiratory illness or pneumonias of unknown origin, unknown etiology, which is the telltale sign of a potential new pandemic. The worst kind of potential new pandemic, a respiratory-driven one, is the speediest form of transmission most often. So those would be important reforms to help make the world safer, and that is what is at stake in that treaty, as is the new treaty being put forward, the Pandemic Accord. There, I am pleased with where the United States has come forward. I think the U.S. has, and hopefully the European Union will follow suit here, has demonstrated that when it comes to the sticky issues, like the pathogen access and benefit sharing provision, where essentially countries are being requested to share the biological specimen and the genetic sequence of a novel virus, and in return are asking for sharing in the benefits from the research and development, the turning of that information into new vaccines.
The technologies that will protect them.
The medicines, the vaccines, the medicines, the test. That has been largely argued from a moral perspective, which is correct, that it's the right thing to do. It has been argued from a public health perspective that it's the more strategic thing to do. The WHO would play a role in a related provision in having 10% of these countermeasures available free and another 10% available at cost to distribute to anyone anywhere in the world that has the highest risk populations in a new novel pandemic. The arguments that I think haven't been leveraged sufficiently that might help move that forward. Number one, if you're in the United States or you're in another rich country and you pay taxes to your government, would you or would you not like to be holding the tab for paying for those vaccines yourself or those therapies in a future pandemic alone? And the G7 nations, which have the greatest chance of coming up with these vaccines and therapies in the future, will, just out of pure self-interest if nothing else, just take trillions of economic loss, dollars of economic loss we had and the millions of lives lost in the COVID pandemic, will eventually have to get to a point, if such a provision is not in place, that asks every nation to do their part in sharing those benefits. They will have to hold the burden on their shoulders. The American taxpayer will have to pay more in that kind of a situation. Would we not want a negotiated platform that would allow dozens of other countries to also commit their fair share, so the United States, for instance, doesn't have to do it alone, or just a handful of countries don't have to do it alone? The second point that I think has been under-leveraged is, while a lot of the framing in the discussion is around what those countries with economic resources and vast amounts of pharmaceutical industry resources would be able to share with low and middle income countries that may have underdeveloped pharmaceutical industries. The other way to look at it is that there is the possibility that the United States or countries in the EU, our allies, may be the first to develop a vaccine in a future pandemic. But it's also not far-fetched to think that our adversaries may be the first to develop a vaccine or a therapeutic in a future pandemic, and or our allies may prioritize their own people first. If you're John Doe and you're in Texas and you're listening to this conversation, you would want to have access to that WHO stockpile that would protect the highest risk people as well in a situation like that. And while, again, the emphasis has been on low and middle income countries, there's no provision in that document that says highest risk people in the highest income countries also wouldn't have access early on. So I think that will be an important, issue to keep negotiating on. It's possible we'll end up with a situation where we'll have a pandemic agreement that has still some provisions that are not yet concluded. This may be one of them. Hopefully it will be sooner than later. But I think those two arguments are under leverage.
I think it's fair to expect that we'll see some kind of skinny agreement in principles and a commitment to create a series of mechanisms for onward downstream negotiations so that there's not a pause, there's a continuity and a seriousness of purpose in trying to reach resolution on these things that do require more time. And that's not the end of the world. I mean, that's progress of sorts. A collapse of this would be terrible. An intermediate set of achievements of the kind I've just talked about is still something valuable. It's not where we all need, but given how stark the divisions have been, it's taken quite a big lift late in the game to get to this point. I do think we're going to see the treaty politicized here at home. I think it's going to be picked up and attacked by Trump and others as an instrument of selling out U.S. sovereignty. And of course, WHO will return to the position of being whipped as this entity that is going to stand in the way of our national interests. But the administration is going to have to deal with that. They're going to have arguments. They're going to have to be out there to defend it and the like.
I agree with you. And I do think that there are enough stakeholders who have something of value in this process. We mentioned the safety of Americans. We mentioned the safety of people around the world. We also, the industry itself has something of value here as well. This kind of agreement makes it more possible to ensure the regulatory apparatus is there so that vaccines get approved safely, but also quickly in countries where there's unmet medical need. That creates the possibility of more markets in emerging markets for companies that are making tough decisions about where they put shareholder dollars in a pandemic. But you're right to point out the concerns around the political concerns. Of course, those are all, just to be clear, falsehoods. This is not ceding in any way authority to the WHO. There won't be. This is the United States has complete sovereignty. The WHO is made up of its member states. And that is important to point out in this situation, that we'll keep that.
One last closing question, which is what gives you the greatest hope and optimism right now?
To me, it's, I was just a month ago in Ethiopia. I'm back on the board at Last Mile Health amongst a number of other activities since finishing up my stint at the White House. I think, and I was in Ethiopia visiting these rural community health workers, two sisters out there who'd been serving for 16 and 18 years out in the mountains of Arba Mensch in the south central region of Ethiopia. And I asked them the same question. Why do you keep doing this work of serving your people? They'd got the COVID vaccination rates up to like 95%. They had just started to recover the measles, mumps, rubella vaccines. They were still struggling with supply chain. They were struggling with all the things you expect in a region of the earth where people have been out of reach of healthcare. Both of them said essentially the same thing. We love our community and our communities love us. We're going to keep going because we love our people. And I think, to me, when we're sitting in places like the Situation Room or around Washington, D.C. or Geneva and elsewhere helping shape global health policy, I have found hope, especially when politics gets in the way or funding doesn't come through, in the stories of people like these two sisters who are still doing the work, who are still committed to the work, a commitment that has been measured not in years, but in decades. And this commitment is not just unique in that one community in Ethiopia. You see it here in communities in the United States. I was in Alaska last 2 months ago and met health workers there who, despite having gone through everything they have during COVID, remain committed to their communities. So to me, I've learned hope is a practice, and part of that practice means being in proximity with the people doing the work.
Great. Thank you. Thank you so much for taking the time to be with us, and thanks for all you've done. It's great to be able to do this, and thank you for agreeing to be part of our work here.
Thanks, Steve.
Thank you for listening to The Common Health. If you enjoyed this podcast, please give us a follow and leave a review. To learn more about the CSIS Bipartisan Alliance for Global Health Security or listen to other CSIS podcasts, please visit csis.org.